All right. Hey, bud, I'm going to give this format a try using Movavi screen recorder. I have Little Scout with me, so if you're wondering where those cute noises are coming from. All right, so first things first, diagnosis. As you identified, class 3, I would say, pretty significant class 3 on the right, molar NK9, less class 3 on the left. Definitely some attrition due to, I would say, increased posterior wear due to increased or decreased anterior guidance. Most likely she wore down these anterior teeth, so when she goes in protrusion, she's wearing these down. Eventually she'll start to wear that cusp down, and that cusp down, and so on and so forth. As you identified, midline shift to the patient's right by 2 millimeters, maybe 3. 50% deep bite or overbite. Retroclined teeth, retroclined lower anterior incisors. Lingualized or tipped would be another way to describe that. Probably some delayed passive eruption. Looks like those crown heights are pretty short, so there's probably some gingival tissue here that could be removed if you decided to for aesthetics. General lingually tipped teeth, probably contributing to the airway. If we look at her, looks like she's got a forward head posture. I'm not sure if you can see my cursor or not, but definitely forward head posture. Looking at her smile, she's definitely a brachy patient, brachycephalic, suggesting that she's probably more likely to be a grinder. When we look at the occlusion, very large spots, suggesting that she's spending a lot of time kind of clenching and grinding. I would definitely say the start of recession due to parafunction, plaque buildup, generalized gingivitis. And as far as tissue, I'm starting to categorize whether the patient is what phenotype they are, so thick or thin biotypes. The reason that's important, thin biotypes, when you're doing orthodontics, have a higher degree of getting recession. Where she's a brachy patient, she's definitely a thicker biotype. Also looks like she had a frenectomy done. Looks like that's scar tissue. So I would surmise that she probably had that done as a kid and hopes to prevent the diastema from getting bigger. Always impressive. If you can tell patients what they had done, they think you're a magician. What else did you have here? Anterior spacing, wide, short teeth with very little clinical crown height. Yes, you had pretty much everything here. Upper anterior segment used to come forward, but two size issues would make really aesthetic. Yeah, very good point. So what I would say here is to solve both of the problems, you really need to interiorize the upper segment. So how do you solve the class 3? Remember when we talked, when you're solving sagittal discrepancies, you have two different ways of solving it. Moving the upper forward or backwards, and then the lower backwards or forward. So in this case, I would focus on bringing the posterior upper teeth forward as a way to close the spaces everywhere. So you would be correcting the class 3, but you'd also be closing these upper spaces so that when you go to restore, you don't have such wide teeth at the end. This might be a case where you want to consider doing a segmental, not a segmental approach, but a kind of a split approach where you first push the anterior teeth forward with a removable appliance, kind of like what I wear, but with an anterior vector. You would create some space, I would say probably behind the canine, and then use Invisalign to pull the back teeth forward By doing that, you're achieving pretty much everything you want, which is increased overjet, helping with freeway space, helping airway, helping with the aesthetics of creating more space on the upper so that you don't have so much of a challenge with the width-length ratio. And then you just kind of adjust the lower teeth accordingly. I think the only thing you need to do on the lower is level the curvus B a little bit and upright these lower molars, which you'd have plenty of time orthodontically to do, because this case is definitely going to take a year and a half to 2 years to do right, so that you get that solution that you're looking for, the aesthetic challenge. Let's see if you had anything else. Sorry about Beckett in the background. You pretty much said it. So I started the video before I read this. This one is out of my league. I have so much other stuff to focus on right now. I'm happy to take this one over. I'm happy to do the ClinCheck for you, and then you can get the credit and just kind of follow the patient along, and I'll help you along the way. As with any Invisalign case, the execution is not the hard part, it's the treatment planning, and I'm happy to do it with you. This is also one that we could do and then send to the ortho coach. I don't think we need to do that. I think you just need to convince the patient of the long-term plan. As far as the aesthetics go, I'm pretty sure you could handle treatment planning that. I'm thinking maybe just a little composite on the incisal edges, and maybe a little bit just to square the kind of, I guess you would call that a distal crown tipping. Well, we'd fix that with Invisalign. So she might not need anything, just some good ortho, and maybe a little bit of composite just to lengthen them after we're done. All right, well, let me know what you think. What's wrong, bud?